advanced ultrasound scan. So I hope we all learned something from his lecture as well.
Good afternoon. I will say some words about the management options for miscarriage, including the manual vacuum aspiration, and also some words about the management of septic abortion. In my talk, I will start with the management of non-viable intrauterine pregnancy, then say some words on retained pregnancy tissue, and end with septic miscarriage. About non-viable intrauterine pregnancy, the first thing to do, of course, is to make the diagnosis, to make a proper diagnosis, and that's very important. Um, and I refer to the paper of Jessica Preisler about how to diagnose it using ultrasound. And the bottom line is, if you don't see an embryo, but you see a gestational sac, and the gestational sac is more than 25 millimeters, mean gestational sac, you can say it's miscarriage. If if there is an embryo and the CRL is more than 7 millimeters, you can also be quite sure it is a non-viable intrauterine pregnancy. If not, you have to repeat the ultrasound in uh, in 7 or 14 days according to the findings to be sure that it's a non-viable pregnancy indeed. So that's very important. As to the different management options, well, there is a nice Cochrane um, review about that, published in 2021, and well, they review the different options, being the surgical options, section aspiration, DNC, and the medical options, being mifepristone with misoprostol or only misoprostol, and lastly, the expectant management. And I must say the results of the Cochrane review is was somewhat surprising for me, coming from Belgium, um, because they looked at the, well, what's the best management to achieve complete miscarriage, and they showed that the surgical methods were the best uh, to have the highest probability to achieve a complete miscarriage, and that followed by the medical methods, and that expected management was the worst. But I have to say, they did not include ultrasound in the diagnosis of the miscarriage management, and also not in the follow-up management or during evacuation and so on. So, but that's what they found. They found the same results as to serious complications um, for the different options, and they didn't do to say that the surgical methods were the most the safest, and that the expectant management was associated with more complications. Complications were included the, well, sepsis, fever, and hemorrhagic complications. But again, ultrasound was not included in the diagnosis. Um, and well, I think we have to look at these results um, in looking at the health accessibility, and that it does not apply for every country. Every setting has its own health accessibility, uh, and if we look here at the satellite photograph of part of the world, and just looking at night, well, we can easily understand that there is a difference in accessibility between Europe and Central Africa, for instance. And even if you look at Europe, you will see that there are hotspots, and I'm living in one of these hotspots here in Belgium. So what applies in those countries may not apply in other countries in the world, and that's something we have to take into account in the management strategies we use. So there is no one fits all solution as to the different management, and what's also important is to discuss that with the patient, to take also the psychological impact of miscarriage into account, and to well, that's something we tend to forget or to neglect a little bit, and to pay attention to the emotional support of the patients confronted with pregnancy loss, and to come to the management after proper information of the patient, the proper support, and then to see what their preference is in your setting, in your country, in taking into account the healthcare accessibility and so on. So what happens in Leuven? Well, in Leuven we have an algorithm. If the patient comes with early pregnancy loss, well, we discuss it. We have a case manager discussing it with the patient, and we discuss the different options, being expectant management, medical therapy, or surgical therapy. And I must say, in our sense, we tend to favor expectant and medical therapy, but that might not be applicable in other parts of the world. One thing I think is important. We always do our surgical therapy, or DNC, the aspiration curettage, we do it under ultrasound guidance. And I think that's something, if you can do it and you don't need a very high-end ultrasound machine to do it, but it really helps, we think. Some words about the manual vacuum aspiration. Is it better? Is it worse than electric vacuum aspiration? Well, there has been a systematic review in in 2008 comparing both modalities, and to keep a long story short, in fact, they both are as effective and as acceptable in the management of in the surgical management of pregnancy loss. They looked at the effectiveness to achieve complete removal of pregnancy tissue, and there was no difference at all. They also looked at the blood loss, and here also there was no significant difference between manual vacuum aspiration and electric vacuum aspiration. They also looked at operation time, and there was might favor slightly the electric vacuum aspiration, but nothing really significant. And but if they ask the doctor what their preference was, the doctors tend to prefer the electric vacuum aspiration, because perhaps it's somewhat more easy, and if you have one, it's well, you tend to prefer to use it. But on a whole, there is both issues, both modalities have the same effectiveness. So second part about the retained pregnancy tissue. First of all, the diagnosis, well, relies on patient history, of course, on the symptoms, pregnancy test, and but we are here for ultrasound. What is the ultrasound diagnosis? Well, ultrasound diagnosis of retained pregnancy tissue is not always that simple, because it's not always that distinct, that clear. But you see some vague, probable, ill-defined area in the cavity. But what's important is using the color Doppler, if you have color Doppler, because you can see more pronounced vessels, hypervascularity in the myometrium underlying the retained pregnancy tissue. Here you see one example, and here also you see here there is an area difficult to see where the retained tissue is, but you see there is something ill-defined here. If you had histography, you will see that there's something harder there, but especially if you switch on the color, you will see that there is focally more an enhanced vascularity of the myometrium underlying the retained tissue. So that's a very important sign. And that brings me to one of the big misconceptions of the last 25 years, and perhaps I think a misused term being arteriovenous malformation. And well, I am also, it's a mea culpa, because I also used it for years. But I think, and I will try to convince you, that we should not use this term anymore. Because, as I said, if you have retained tissue, underlying the retained tissue, you will have enhanced vascularity of the myometrium, and this enhanced myometrial vascularity. In fact, if you see that, you may almost be certain that there is retained pregnancy tissue, and this might be quite some retained tissue, but sometimes you see only a little flat plaque of retained tissue, but there is a retained tissue, and due to the retained tissue, there is some arteriovenous shunt here, causing this enhanced myometrial vascularity. And in practice, if you see that, and if you remove the retained tissue, the vessels will disappear and bleeding will stop. That's the rule. That's the rule. And so don't use the term arteriovenous malformation. Why? Because, well, it's arteriovenous, of course. Just remember your physics lessons. You need a difference in pressure between arterial and a venous bed, but it's not a malformation. It's part of physiology. So enhanced myometrial vascularity is associated with retained pregnancy tissue in almost all cases, and that's due to the presence of AV shunts at the base of the retained tissue, and this is almost always due to that. There are exceptions indeed. You can have also AV shunts. That's post-traumatic. That's something that happens after DNC, operative hysteroscopy, myomectomy, caesarean section, when you have a iatrogenic shunt between an artery and a vein, and causing an AV shunt, and that's something you can see, but that's not pregnancy associated. Who says that? Well, we did some work on this topic for years. We published the first, I think the first time we used enhanced myometrial vascularity was it was 20 years ago. In the meantime, other centers and other authors also use it all over the world. So it's not only a Leuven term. And just in this month in the White Journal, you can read our opinion paper about enhanced myometrial vascularity, and invite you to read it. And why is it important? It is important because of the management. Okay, because if you see enhanced myometric vascularity, it's most probably due to retained pregnancy tissue. What do you do? Well, if there is no bleeding, you can wait. If there is heavy bleeding or persistent bleeding, you should remove it surgically. Uh, you might do it by hysteroscopy if there is not too much bleeding, but if it bleeds quite heavily, you should do it under ultrasound guidance. And again, once the tissue is removed, the bleeding will stop. If it does not stop, you can well, there are some maneuvers we all know: emptying the bladder, uterine massage, and uterotonics. What we use quite often, if there is still some bleeding after the procedure, is to just insert a bladder catheter and to inflate the balloon into the uterine cavity. So we put the bladder catheter into the uterine cavity and you give some pressure for 1-2 hours or 24 hours if it's heavy bleeding. And the thing is, embolization is really the exception. Okay, we use it very, very rarely. If you use this algorithm, you will save the patient embolization in most cases. Okay, this was about retained products of conception. If it's not septic, in fact, you have the choice to be expectant to do surgery and so on. But if it's septic, then it's an urgent situation, and then you have no choice. Then you have to remove the septic tissue and to give antibiotics to avoid the need to do a hysterectomy or to avoid patient death, because septic miscarriage is due to retained tissue that becomes necrotic. Then there are bacteria invading the tissue. You will have toxins produced by these microorganisms, and within hours you may have a septicemia. And we all know that septicemia is heavily dangerous for the patient and can cause severe acute respiratory syndrome, DIC, septic shock, and even death. So that's an emergency. And if you think there might be a septic miscarriage, septic tissue inside the uterus, you have to remove it now and to start with antibiotics. Then there is no place for expectant management at all. What's the use of ultrasonography? Well, in the diagnosis, the clinic and the lab test is the most important. At ultrasound, well, on grayscale, you might see some echogenic spots due to gas production, due to anaerobic bacteria. Color, well, if there is necrosis, usually, well, it's necrosis is avascular, so if you don't see a lot of color, that's not reassuring in septic abortion. Okay, and also as to site-specific tenderness, where you expect it to be tender, to be painful because it's septic, but if the patient is really septic, you may underestimate the site-specific tenderness. So be aware of that. But so the treatment of septic abortion is surgical removal as soon as possible, antibiotics, and use the sepsis protocol. And if you do the removal, do it under ultrasound guidance to avoid perforation and to enhance, to improve the completeness of the tissue removal. And you don't need a high-end machine to do that. We use it transabdominal ultrasound in most cases to guide the removal. Sometimes transrectal approach using a transvaginal probe is more easy, especially according to if the uterus is retroflected or if the BMI is high. But use your ultrasound machine in the OR. It makes life so much easy and so much and more safe for the patient. Okay, thank you.
Thank you very much. Excellent, Professor Terry. It's Very insightful lecture again on a rather very important topic. I guess the MVA practice, it is more utilized and useful, perhaps applicable for limited resources settings and condition. I was just inquiring again to share my thoughts with Tom for chronic retained products. There is a new concept, at least for me. I started to learn it as well and practice it for hysteroscopic resection with MyoSure to excise the retained products rather than MVA. Although the applicability of ultrasound now has reached so fast that you can apply it, take it with you to the clinic, take it with you to the outpatient procedure room, or even take it with you to theaters. So is there any data, any comparable outcomes between hysteroscopic resection of retained products and office time?
Thank you. The thing is, if the patient is not bleeding that much, I think it's if you can do hysteroscopy and to remove it on the hysteroscopic guidance, I mean that's the best way to do it, and it's very easy. You don't use electricity, just use the cold
Mechanical,
loop,
yes,
just
absolutely.
cold loop, so no electricity, and that's works very well. But the thing is, if it bleeds a lot, I mean, at hysteroscopy you don't see anything but a red red flag. So in those cases, well, you have to switch to ultrasound. And the thing is, even if you think you will do it with hysteroscopy, just have your ultrasound machine already ready just beside the patient, because if it starts bleeding, you don't have time to say, well, come fetch the machine, and then it takes 10 minutes for the machine to come and to. So just put your machine next to the patient at the start of the operation.
Absolutely, yes. Excellent.
Can I just ask a question to you? I mean, it's just how long do you wait? You know, because if you have tissue there and you think it's going to, you often have a patient and you think it'll just pass. And well, the problem, of course, is if they're breastfeeding and they don't have periods, number one, and you've also got a relatively hypoestrogenic endometrium, so you kind of think you can damage it quite easily. So kind of what do you do? I mean, do you tend to say if they're having periods, let's wait until you've had a period and see, because some of it will pass. But is there a time point where you just think we might as well take it out, because if they're not bleeding, it seems unlikely that this is going to resolve? I mean, how do you kind of manage it in practice?
I think that's well, we tend to be conservative and more conservative the last years, but I think it depends on the setting also. If you're in a setting where you're at 6 hours from a hospital, perhaps if you see it, you better remove it straight away than to wait. But if you have a patient who have access to the hospital, you can inform her, and if she has pain or bleeding or so on, then she can come immediately to the hospital. Then it's perhaps a safe option to wait. So I think it depends on the setting.
Okay. Thierry, I think we probably have to stop at this point, Thierry, because we're running slightly late and we need to move on. Thanks very much. I like the new voice. You've obviously have a bit of a cold or something with you when you recorded your last lecture. Very like this is the new Matt. This is the new Thierry Vandenbot.
I'll work on it.
The Royal College. Anyway, I hope you go and have a lemsip or whatever you have in Belgium. Okay, I'll speak to you soon. Thanks so much.
Thanks.
Excellent. So
now our next speaker